withdrawal of the anesthetics. SRSC recurs in 4 to 16.9% of status epilepticus cases, and the mortality rate is around 5% in children with SRSC. The functional outcome in survivors depends on the seizure duration, underscoring the need of achieving the rapid seizure termination. Here I go ahead with the case details. We have a 7-year-old pre-morbidly normal, happy school-going boy hailing from Trichy who had onset of seizures on 31st August 2020 following a febrile illness necessitating admission in hospital locally. The seizure frequency was increasing and there was progressive decline in sensorium. Pediatrician and neurologists tried their best to achieve the seizure control. However, despite their efforts, seizures were relentlessly progressing and he was referred to us a pediatric neurology wing, and we provided logistic support for transfer and received the child in ER. On arrival in ER, we have stabilized him hemodynamically and optimized the ongoing anti-epileptic drugs, and he was shifted to PIC. He had 30 seizures per day initially, despite maximal anti-epileptic drugs, which included 5 anti-epileptic drugs and IV midazolam infusion. Seizures were progressively increasing and refractory to the anti-epileptic medications and reaching a crescendo up to 40 per day, turning into super refractory status epilepticus. He had already received one incomplete course first-line immunotherapy, that is IV methylprednisolone and IVIG outside. And on examination, he was drowsy. GCS was 13/50. He was hemodynamically stable. Systemic examination was normal. Neurological examination was normal. There were no cranial nerve deficits, motor or sensory deficits. This is a seizure recorded at our hospital. So this is a right-sided focal seizure with impaired awareness. Clinical summary: he's a 7-year-old boy, a pre-morbidly normal boy, presented with new onset super-refractory right focal seizures following a febrile illness and failure of response to first-line immunotherapy with no focal deficits or cranial nerve palsy. The possibilities considered were CNS infection. The points in favor were seizures provoked by febrile illness, and the points against CNS infection were there were no meningeal signs, vomiting or headache. Second possibility considered was structural epilepsy due to unifocal seizures at onset. However, the age of presentation is against structural epilepsy. Third possibility considered was CNS vasculitis, as it was a fever-provoked focal seizure, and there were no systemic manifestations or focal deficits. Fourth possibility considered was Rasmussen's encephalitis due to unifocal seizures, but there were no focal deficits or hemiparesis. The fifth possibility considered was autoimmune encephalitis, as it was a fever-triggered seizure turning into SRSE. However, there were absence of psychiatric symptoms, cognitive regression, and movement disorder, which is against autoimmune encephalitis. So, in initial evaluation done showed HP of 9.8 and total counts of 11,800. Platelet was normal. LFT, RFT, ammonia, serum electrolytes were normal. Complements were normal. ESR and CRP were normal. We have done an LP and CSF analysis done showed no WBC count, and sugar was 71, which was normal. CSF culture was normal. CSF biopsy panel was done, which was negative, and CSF oligoconal blanks were negative. We have done viral markers and were negative. So hence, since CSF analysis was normal, possibility of CNS infection has been ruled out. And we have done MRI brain, which was normal. So structural epilepsy has been ruled out. Vasculitis panel was done, which was negative. Hence, we have ruled out CNS vasculitis. Now, the possibilities considered were Rasmussen's encephalitis and autoimmune encephalitis. We have done an inferrectal EEG, which showed bilateral diffuse bifrontal slowing, and there was no evidence of hemispheric dysfunction or delta brushes. Now we have done a PET CT as MRI was normal, and in Rasmussen's encephalitis, at presentation in the initial phase, the MRI brain could be normal. However, we have done PET CT to rule out any hemispheric hyperintensities and also to rule out any focal occult neoplasms, which showed bilaterally symmetrical hypometabolism in parietal and temporal regions. So these are the new PET CT pictures which showed bilateral hypometabolism in parietal and temporal lobes. Hence, we have ruled out Rasmussen's encephalitis. And the final possibility and the only diagnosis which we can consider now is autoimmune encephalitis. So we have done an extensive neuroimmunology workup, which was negative, and we have also done thyroid profile to rule out any autoimmune thyroiditis, which was normal. Now comes our eureka moment, and we have done serum anti-GAD antibody levels, which was turned out to be positive. The value is 221 international units per ml. Final diagnosis, we have made a final diagnosis of new onset focal status, super refractory status epilepticus, underlying cause being anti-GAD 65 encephalitis. And now we have unleashed three-pronged management strategy, wherein we have given multiple anti-epileptics and added varicitam, which is the latest molecule in therapeutic armamentarium, and aggressive immunotherapy, including rituximab infusions, and intensive 4:1 formula-based classic ketogenic diet. However, the child had multiple challenges during the course of illness. We had 3 failed extubation attempts, which were appropriately managed with steroids, and also we have done an FOL, which showed to rule out subglottic stenosis, which showed vocal cord edema. And he also had relapse of the disease following. This is new onset seizures after he has received first dose of second line immunotherapy, that is rituximab infusion. So here comes the summary of this child. He has been hospitalized for 45 days in our hospital. During the course of stay, initially, the child had 30 to 40 seizures per day, and he was on midazolam infusion and multiple anti-epileptics. The seizure frequency has been day by day increasing. Hence, we have approached the case with a three-pronged management, wherein rivaroxaban, a newer anti-epileptic drug, and other anti-epileptic drugs, midazolam infusion, keto diet, has been started initially at a ratio of 4:1. And we also completed the first-line immunotherapy as he was inadequately treated outside, following which the seizure frequency has come down. Hence, we have reduced the keto diet to 3:1. There was increased frequency of seizures. Meanwhile, he also had extubation failure, and also he had nosocomial infection in the form of urosepsis. His urine culture grew enterococcus faecium, and he was appropriately treated with antibiotics. Following the resolution of the urosepsis, we have started him on rituximab infusion, 375 mg per meter square. First dose was given, and have continued the classic keto diet at a ratio of 4:1. Seizures have been well controlled. However, he had a stormy course, and there was relapse of seizures. Hence, we have given the second dose of rituximab infusion, and following which his seizures have come down and he has been seizure free. So the challenges which we faced during the treatment of this child were nosocomial infections in the form of urosepsis, which was treated with antibiotic therapy. He also had 3 failed extubation attempts, which was treated appropriately with steroids and adrenaline nebulization. We also have done FOL to rule out any subglottic stenosis, and found out that he had vocal cord edema. Refractory seizures and neurocritical challenges were managed by our three-pronged approach. And due to COVID, the father has also lost his job, and they belong to a middle-class family. Hence, we have supported the family through our crowdfunding. So he fought the battle valiantly against all the odds and was successfully discharged on keto diet and anti-epileptic drugs. He has been all the while seizure-free and has been attending his online classes. On follow-up, we have done CD19 levels after 2 doses of rituximab, and it was found to be less than 0.1%. He has been on regular follow-up with us and on tapering of anti-epileptic drugs and keto diet, has been slowly tapered. So they have been extremely grateful and thankful for the meticulous attempts made in controlling the seizures and improving the child's condition. And we have celebrated we have discharged the child and have sent him home by a small celebration. So anti-GAD encephalitis. What is GAD? What is GAD? It is an intracellular enzyme which is expressed in neurons and insulin secreting pancreatic beta cells. The physiological function of GAD is the decomposition glutamate to GABA. A review article published in 2016 has reported 58 published cases with 37 in adults and 21 in pediatric age group. Anti-GAD antibody has been hypothesized to have an inhibitory effect on the synthesis of GABA in the synaptic vesicles and its synaptic release. The clinical features of anti-GAD encephalitis were focal seizures, cognitive and memory decline, progressive developmental delay, psychiatric symptoms. Other systemic manifestations associated with anti-GAD encephalitis are type 1 diabetes mellitus, systemic autoimmunity, thyroiditis, pernicious anemia, celiac disease, and vitiligo. The differential diagnosis for anti-GAD encephalitis was stiff person syndrome, limbic encephalitis, temporal lobe epilepsy, and cerebellar ataxia. The lab findings could be CSF may be normal or may show oligoconal bands. MRI and EEG may show abnormalities arising from the limbic structures. Although anti-GAD encephalitis is associated with various paraneoplastic syndromes, patients with anti-GAD antibodies usually do not have any underlying tumors. The first-line therapy recommended is IVIG and steroids. But however, if the patient remains significantly impaired after first-line therapy, second-line treatments are typically used. The second-line therapy that can be used is rituximab, often 375 mg per meter square weekly for 4 weeks has been recommended, or cyclophosphamide or both. Rituximab acts by depleting CD19 plus or CD20 plus B cells. Due to relative favorable safety profile, rituximab is preferred to cyclophosphamide. This is a review of literature which I have done. And we thank all the people involved in the management of this, Dr. Priya, who has referred us this case, and PICU team, who has meticulously helped us in, who have put their meticulous attempts in bring the child out of this stormy course, and electrophysiology department, Dr. Prasanna Kumar, ENT specialist, and Shali, dietitian. So the child has been doing well. Discharge. Thank you.
Okay. Thanks for a very good presentation. We need to cut cake for your team too. Okay. Definitely yes. Questions will be answered at the end of the session by respective team. And let us go to the next case. It is new onset severe diabetic ketoacidosis, a twist in the tail. Presenter Dr. Kirti, PQ team, and Dr. Soundaram. Over to you, Ma. Start your presentation. Time is 2:44, exactly 10 minutes, not more than that. Please stick to your time.
Yes, sir.
Share your screen and start presenting.
Okay, sir. Sir, is the screen? Is screen, sir?
Done. Start.
I'm telling everyone, nobody is saying okay.
Good afternoon, everyone. I'm Dr. Kirti, PSU Fellow from Apollo Children's Hospital. Today, I am going to discuss a case of new onset diabetic ketoacidosis at Vistil. Moderator is Dr. Vasant Kumar, sir. This is our PSU team. Coming to the case details, this is a 5-year-old male child who had history of polyuria and polydipsia for 10 days, decreased activity for 4 days, and had fast breathing for 2 days. He was presented in a shock state at a private hospital where he was resuscitated, diagnosed to have new onset type 1 diabetes mellitus, it's severe DKA, and he was started management as per the ISPAD guidelines. He initially improved to the standard treatment. His first blood gas was showing a pH of 6.9, bicarbs of 2, PCO2 of 10, and sugars were 428. The shock has resolved. Coming to the case progression, after he had improvement in DKA parameters for the first 24 hours, after which he started having new issues. He had oliguria and there was recurrence of acidosis. So issues were like ketosis was settled, acidosis was worsening, there was tailing urine output, and additionally he had a drop in sensorium. The serum creatinine was done, it was 0.9 milligram per DL. As there was no response to fluids and Lasix, he was referred to us for renal replacement therapy. At the time of admission, he had a GCS of 13/15. He was tachycardic and tachypneic. It was disproportionate tachycardia, but sinus tachycardia. His temperature was 98.6. He had a blood pressure of 90/60. He was not hypotensive. He had cold peripheries and prolonged CRT. His weight and height were appropriate for his age, and physical examination showed periorbital puffiness. And systemic examination wise, he was lethargic and not easily arousable. Perabdomen was soft, but there was no significant hepatomegaly. Respiratory wise, he was tachypnic, but no creps or no added sounds were seen. So the new issues were he had persistent acidosis. This is the initial blood gas done at our hospital. It showed a pH of 7.49, PCO2 of 15, bicarb of 12, and base excess of minus 13. We considered it like we can call it like persistent acidosis when bicarbs are less than 10 despite 8 to 10 hours of therapy. Here we bicarbs were 12, but in the previous hospital he already received bicarb correction, so we considered it as persistent acidosis. So the new issues the issues were he had compensated shock. Blood gas was showing both high anion gap and non-anion gap metabolic acidosis. So we were thinking of sepsis, dehydration, ketoacidosis, acute kidney injury, and cerebral edema. So coming to the approach, he had a tailing urine output. His urine output was like 0.5 ml per kg per hour for the last 6 hours. He comes under risk category according to the P-Rifle criteria. Most common cause of acute injury in diabetic DKA is dehydration, but he was adequately hydrated. So we started him on relative fluid strategy, calculating for urine output and insensible losses. He had drop in sensorium, so cerebral edema was considered. He was at risk of cerebral edema because he had a severe DKA presentation, younger age. He also received bicarb correction, and PCO2 was very low, 10. But the serum osmolarity we calculated was 312. There was not much significant drop in osmolarity. Hyperchloremia also contributing to acidosis was checked. Chloride levels were 121 millimoles. So we changed fluid to balance crystalloids, plasmolite. For the dehydration, other than tachycardia, he was adequately resuscitated. He had a positive fluid balance. IVC was dilated, and periorbital puffing was present. So dehydration was not considered. We checked whether insulin correction was going properly or not. Blood sugars were normal, 200 milligram per DL, and the insulin infusion we continued at 0.05 units per kg per hour. Ketoacidosis was also thought of, but serum hydroxybitrate was 0.7 millimoles, which was normal. Sepsis was also considered as he had new onset organ dysfunction with high lactates and anion gap of 17, but he didn't have any history of fever. Anyway, we sent the cultures and started him on broad spectrum as he was had a previous admission in hospital. We started him on PIP test. As there was no response, persistence of shock was there. As a routine protocol, we have done a bedside echo which showed dilated LV with severe LV dysfunction with an EF of around 25%. This is a video showing a dilated LV, the paradoxical. I'll play with paradoxical interventricular septal motion. This poor approximation of the walls, and it can be made out even by eyeballing alone without calculating the EF also. X-ray done at the time showed mild cardiomegaly with congestion of both lung fields. So as for the management, along with the conventional DKA protocol, we have started him on dobutamine infusion at 5 mg per kg per minute. He also received a stat dose of Lasix 10 mg, post which after 2 hours his perfusion improved, urine output started increasing, and acidosis also was improving. This is a table showing serial improvement in blood gases. Day 1 was at the time of admission. He had a bicarb of 12, which improved to 27 slowly. There was improvement in base excess, and creatinine was done on day 1 was 0.9. We have repeated on day 5, it was 0.4. So once we intervened, there were improvement in all the parameters. For the endocrine part, he was on insulin infusion, like at the rate of 0.02 to 0.05 units per kg per hour. Though the sugars and ketones were normalized, we still continued on insulin infusion as he was critically ill to avoid fluctuations. On day 4, he was changed to subcutaneous insulin. On day 7, he was discharged. For the cardiac part, he continued dobutamine infusion for 76 hours. Cardiologist opinion was taken. Enalapril and digoxin were added. Repeat echo on day 5 showed improvement in contractility with EF of 60%. At discharge, we stopped digoxin, and enalapril was continued till next follow-up. In the follow-up, echo and ECG was done, which showed normal heart function. So we stopped in the next follow-up. No central line was placed for this child, and he was managed with peripheral access alone, EJV. the child improved well, and now he's doing good. For the discussion part, acute kidney injury in DKA, or what, like the child had only like new issues for oliguria. So he had acute kidney injury. So it is usually secondary to volume depletion, which occurs in DKA. It improves once we correct the pre-renal cause. Other causes are urinary losses of ketone anions contributing to impaired normalization of serum bicarbonate upon resolution of DKA, resulting in persistent hyperchloremic metabolic acidosis. This chloride regulates renal blood flow by glomerular feedback. That is the reason why hyperchloremia contributes to AKA. Here, this is the diagram showing the high chloride levels are sensed by the macula densa, which causes release of local mediators stimulating the afferent arteriole, and the afferent arteriole constricts, thereby decreasing the renal blood flow and decreasing the GFR. Other common causes are sepsis and rhabdomyolysis, and other is congestive heart failure. Here in this case, we attributed this to cardiac dysfunction, because even before the correction of chloremia, there was improvement in acidosis, and sepsis was ruled out. There was no pre-renal volume loss and volume, he was adequately resuscitated, hydrated. So the reason for myocardial dysfunction in DKA, we have done is creatine phosphokinase levels on day 3 of admission. It was 268 units per liter. It was high, but not significantly high, because it was done a little later. The common causes of myocardial dysfunction. He had severe hypophosphatemia. Dyslipidemia is the most common cause of myocardial dysfunction. He had severe hypophosphatemia, hypokalemia, and hypomagnesemia, which were addressed. He also had hypocalcemia and hypovitaminosity, which we started treatment for that. Hypothyroidism was also thought of, but her thyroid profile was normal. Viral myocarditis, we deferred because there was no history of any fever, viral prodrome, or rash, and there was also a fast recovery in cardiac dysfunction. And sepsis, the sepsis cultures were negative, and total counts were like 7,490. So sepsis was ruled out, and antibiotics we stopped after 48 hours. As the child was admitted in the month of September, we did a COVID testing. Both antigen and antibody were negative. Other causes like metabolic acidosis and high serum osmolarity also contributing to myocardial dysfunction. It was little high. The osmolarity was high, 314 milliosmoles per liter. There are 2 other case reports showing myocardial dysfunction associated with diabetic ketoacidosis. This is a case report of 5-year-old child who had severe DKA, presented in shock, also had cerebral edema. Later on, she progressed to have respiratory failure, secondary to
Kirti, unmute yourself. Kirti, unmute yourself.
Sir,
unmute yourself. I have muted all. Please unmute. Now you are audible. Okay, proceed.
He is audible now.
Yeah,
you can speak. Yeah, go ahead.
So this is a case report showing a 5-year-old girl who had severe DKA, presented in shock, progressed to have cerebral edema, and later on she developed respiratory failure, secondary to cardiac dysfunction, and she improved with inotrope support. This is one more child, a 9-year-old female child who also had severe later on distress and pulmonary edema, myocardial dysfunction. In this child, troponin levels were done, which was elevated. He also had ECG abnormal changes. Both these kids responded to inotrope support, but as they stated, like fluid boluses were intubation and a long duration for recovery. In our child, actually, it was intervened early, so he didn't require any intubation in our child. Other reasons for cardiac dysfunction, other than previously mentioned, the Severe decay initiates synthesis of antibodies to self-antigens like myosin, vimentin, and K-alpha-1 tubulin, which might contribute to diabetic cardiomyopathy. Myocardial injury is associated with elevation in troponin T and creatine kinase levels. We didn't do
Time up.
troponin T
Make it
levels
fast,
in
ma'am.
our because it was quite obvious. The cardiac dysfunction was quite obvious. Acidosis and high free fatty acids cause membrane instability and cardiac dysfunction in DKA. Take home message: the cardiac dysfunction is a rare but recognized complication in DKA. This case demonstrates the need to closely evaluate and monitor cardiac function in patients with DKA in whom shock is not resolving, or there is persistent acidosis, or there is recurrence of shock or acidosis. So early identification with point of care echocardiography and initiation of cardiac supportive measures prevents further organ dysfunction, averts the need for organ support, and shortens ICU stay. Along with that, bicarb correction should not be given in DKA management. Thank you, sir. I thank City Pediatric Meet Committee for giving me opportunity to present here.
Okay, ma'am. Thanks a lot. Questions will be answered at the end of the session. Requesting participants to mute your mic, please. And we will go to the next topic, an unusual case of hypoglycemia in 2 children by Dr. Manoj Madhusunanam. Team includes Dr. Janani Shankar and Dr. Venkadeshwari from KKCTH. Over to you, Madhu. Share your screen. Kirti, please stop sharing. Manoj, over to you. Start.
Yes, sir.
Time is 2.578 minutes. Please.
Can you see my screen, sir?
Yes. Audible, visible. Go for slideshow. Start.
Good afternoon, everybody. I'm going to be presenting a child with an unusual cause of recurrent hypoglycemia. This case is from Dr. Janani Madam's unit from Children's Hospital. So the child here is a 2.5-year-old boy, first born to non-consanguineous marriage. There was no significant perinatal history and he was developmentally normal. On past history, child was admitted elsewhere 6 months ago with 1 episode of seizure. The seizure occurred early morning at 8 a.m. He had documented hypoglycemia during the episode, and further evaluation during that episode revealed ketosis, lactic acidosis, hypertriglyceridemia, and hyperuricemia. An ultrasound abdomen done there revealed altered echo textures in the levels. So they had rightly suspected a possibility of GSD1. However, in view of this COVID lockdown situation, further evaluation was not possible at that time. So 6 months from then on, child presented at KKCTH with second episode of a similar early morning seizure. Stick sugar done at admissions revealed hyperglycemia again. On examination, he didn't have any abnormal faces. His anthropometry was normal, and his abdomen examination was soft, and there was no hepatomegaly. So again, he was evaluated in detail. Critical samples revealed sugar of 17 mg per deciliter at admission. He also had lactic acidosis of 6.9, hyperuricemia with uric acid values of 8. However, his triglycerides were normal during the admission. His liver enzymes were also normal, and his ultrasound abdomen again revealed a normal liver, unlike the ultrasound done before. So before I go into further evaluation of this child, I would like to give a brief approach to hypoglycemia, recurrent hypoglycemia in any children. So hypoglycemia in a pediatric age group is usually defined by the Whipple's triad, that is plasma glucose level of less than 55 mg per deciliter, associated symptoms of hypoglycemia, and reversal of these symptoms with administration of glucose. So in a normal individual, following a feed, utilization of dietary glucose by action of insulin occurs during the first 3 to 4 hours. Glycogenolysis takes over as the principal source of energy during the next 6 hours of the child. And the gluconeogenesis forms the main source of glucose in a child with more than 12 hours of fasting. So any hypoglycemia occurring within 3 to 4 hours, hyperinsulinism is the most common cause, whereas those occurring between 6 to 12 hours are classical GSDs which present with early morning hyperglycemia that forms the major cause. And disorders of gluconeogenesis include fructose 1,6 bisphosphatase deficiency or phosphoenol pyruvate carboxylase deficiency, also present with early morning hyperglycemia. So in response to hypoglycemia, there is a reduction in secretion of insulin. However, there is a rise in secretion of hormones such as cortisol and growth hormone. Glycogenolysis and gluconeogenesis is on the increase. This is a very important part in evaluation of any child with hyperglycemia because main part of gluconeogenesis is conversion of triglycerides to free fatty acids and free fatty acids to ketones. Insulin, does the conversion of triglycerides to free fatty acids, and fatty acid oxidation helps in conversion of free fatty acids to ketone bodies. So evaluation of any child with hyperglycemia, we have to first split them into whether they are ketotic or non-ketotic. In a child with non-ketotic hyperglycemia, evaluation is fairly simple. The first step we have to do is check urine for reducing substances. Positive urine reducing substances makes galactosemia a common cause, whereas a negative urine reducing substances puts the diagnosis in hyperinsulinism or fatty acid oxidation defect. However, in ketotic hyperglycemia, there are a lot more details. The first step in evaluating a ketotic hyperglycemia is to find whether the child has acidosis or not. In a child with acidosis, the two common differentials are gluconeogenesis defect and organic acidemia. The differentiating part is that lactic acidosis occurs in gluconeogenesis defect. If there is no acidosis, the differentials here are either GSD except GSD1, which presents with lactic acidosis, or growth hormone and cortisol defect, and the other cause is idiopathic ketotic hypoglycemia. Here the differentiating part between these two is the presence of hepatomegaly. So any child presenting to the ER with recurrent hypoglycemia, history should involve family history, whether any sibling death or any similar illness in the family. Time of occurrence of symptoms. As I told you, hyperinsulinism presents early, within 2 to 3 years of age, whereas GSD and gluconeogenesis defect present with early morning hypoglycemia. Clinical examination involves looking at the face for cherubic facies, classic glycemia and GSD, anthropometry for growth hormone defect or multiple pituitary hormone deficiency, hepatomegaly, again a classical feature of GSD, and genital examination for again multiple pituitary hormone deficiency. Laboratory investigations differ for ketotic and non-ketotic hypoglycemia. For ketotic hypoglycemia, as I told you before, urine reducing substance to look for galactosemia, insulin and C-peptide levels for hyperinsulinism, and free fatty acid levels, which will be characteristically low in hyperinsulinism and normal in fatty acid oxidation. Non-ketotic hypoglycemia, as I told you, lactic and uric acid levels are a predictor of gluconeogenesis defect, and cortisol and GH level can be done. So in our child, he had ketosis, putting it as ketotic hypoglycemia. He had acidosis, and he had lactic acidosis, which was the reason. So this puts the diagnosis as gluconeogenesis defect, and we have to classify it further. So ketotic hypoglycemia with lactic acidosis and hyperuricemia is a marker of gluconeogenetic defect, most common of which is GSD1. However, our child did not have the characteristic cherubic facies, and his liver was absolutely normal. So since it was the second episode of seizure, we directly went ahead with a genetic analysis, which revealed compound heterozygous mutation for fructose 1,6 bisphosphatase deficiency, again which is a gluconeogenetic defect. So a brief overview of fructose 1,6 bisphosphatase deficiency. As I told you, it's a disorder of gluconeogenesis, presents with recurrent hypoglycemia triggered by a high fructose load. Ketotic hypoglycemia with lactic acidosis and hyperuricemia is a common manifestation, and there will be absence of organomegaly. So here is the enzyme deficient in fructose bisphosphatase deficiency, and this is GSD1. So since they are in the same pathway, it presents with biochemical parameters which is very similar to GSD1. However, glycogenolysis occurs and it joins the gluconeogenesis during this part. Hence, glucose phosphatase deficiency presents with hepatomegaly and early morning hypoglycemia. The main dietary advice is to avoid fructose, sucrose, and sorbitol. Most important thing as a pediatrician is all syrup formulation, including paracetamol, have fructose content and should be avoided. The parents were counseled regarding the management of this. Uncooked starch given at night has a role in preventing the early morning hypoglycemia. So take home message, clinical examination and collection of critical samples are essential for accurate diagnosis of child with recurrent hypoglycemia. Fructose 1,6 bisphosphatase deficiency is a close mimicker of GSD1, and requires fructose restriction alone, unless unlike GSD1, which is a very morbid disease. Thank you.
Beautiful, clear, crisp, a fantastic presentation. Anyone can understand. Fantastic presentation. Now, okay, you can post your questions in your chat box. Now, paroxysmal dyskinesia in a child by Dr. Hemanandani from Stanley Medical College, from team which includes Dr. Veluchami. A similar case was presented a month back, it seems. Okay, over to you, Dr. Hemanandani. Share your screen. Madhu, are you there? Am I audible and visible? Okay, then. Madhu, unmute yourself. Am I audible and visible to you? Madhu, you can.
Am I audible, sir?
Yes, start your presentation.
Okay, sir. Good afternoon to everyone. Today, my presentation is on paroxysmal dyskinesia in a child. My moderator is Dr. Velusamy, sir, HOD of Chief of Department of Pediatric Neurology, Institute of Social Pediatrics.
Madhu, you have any connectivity issues? Hemanandini?
No, sir.
Start presenting, please. You are not audible, ma. Start.
Yes, sir, now.
Okay, you are audible right now, visible.
Hello, sir.
Then start.
Is it audible now, sir?
Audible, visible. You are right now on history. Proceed.
Yes, sir. History. Yes, sir. Okay, sir.
Start.
Yes, sir. A 10-year-old girl child born for a non-consanguineous parents presented with his frequent falls of 2 years duration, as per mothers while playing or while walking for a few steps. There was no loss of consciousness during the episodes. These episodes were sudden in onset without any prior warning. Child gets up immediately, and the child used to get similar episodes, 1 to 6 episodes per day. On examination, child was conscious, oriented, and there was no pallor, cyanosis, or no clubbing, and no pedal edema, not ectric. There is no generalized inflammability, no neurocutaneous markers, and there is no KF ring. Vital signs regular in rhythm and
Ranjit, mute yourself, ma. I think we have some issues with the connectivity. Janani ma'am? I think she has some connectivity issues. Madam, shall we go for the
Why don't you go for the next case? Yeah,
okay.
Go for the next case and maybe she can go on later.
Okay, madam. So next case is from okay, Hema Sankari, you have some problem in your connectivity.
yes.
Okay, please proceed.
Sir,
if you have some issues, we'll go for the next presentation. You can join us at the end of the presentation. Right now, you can proceed, please.
Yes, sir. Systemic examination, central nervous system, higher mental functions were normal. There was no cranial nerve deficits. Motor examination was normal. Sensory system examination were intact. No cerebellar signs or meningeal signs. No, there was no autonomic disturbances.
I think she's again stuck.
When child was asked to walk a few steps, child was noted to have a dystonic posturing of both upper limbs and lower limbs, which lasted for a few seconds without any loss of consciousness. This is a video showing the child with posturing. The consciousness is intact during the episode. Other system examinations were normal. Other system examinations were found to be normal. On investigations, found hemoglobin was normal, 11.9, W 4.6 lakhs. RBC is peripheral smear is normal, stating RBC was normal, one or two. Secondary causes were ruled out. Total evaluation was done, and there was no KF link. Thyroid function is proximal kinesogenic dyskinesia. Child was started on tablet carbamazepine, which is 200 milligram half BD was started initially. After starting on tablet carbamazepine, there was no recurrence of the episode. Child was free of episodes. After 1 week, child had skin rashes. Suspecting the carbamazepine rashes, drug was stopped. After stopping of drugs, child had the episodes. So after 1 week, child was again started on tablet phenytoin. After starting phenytoin, the child is free of episodes now. Discussion part, paroxysmal dyskinesia, it is an uncommon group of motor movement disorders. It is characterized by attacks of sudden involuntary movements without any loss of consciousness. Based on the duration, it is short lasting, which is less than 5 minutes, or long lasting more than 5 minutes. Based on Demirkiran and Janvik classification, it is classified into 4 types, which is paroxysmal kinesogenic dyskinesia, which starts immediately after the sudden movement of the body. Second is non-kinesogenic dyskinesia, which is initiated by caffeine, alcohol, or other drugs, which is not by sudden movement of the body. And paroxysmal exercise-induced dyskinesia, it occurs 10 to 15 minutes after an exercise. And GLUT2 transporter mutation can also be associated with the paroxysmal exercise-induced dyskinesia. Paroxysmal hypnogenic dyskinesias, which occurs during the sleep, most commonly during the non-REM sleep. Most common type is the paroxysmal kinesogenic dyskinesia. It is characterized by episodes, which is paroxysmal, which is aggravated by the sudden voluntary movement, which is kinesogenic, and resulting in an involuntary movements dyskinesia. Usually the onset will be less than 20 years, may vary in secondary causes. Based on the etiology, it can be primary or secondary. Primary, which is familial, most commonly autosomal dominant, or some cases will be sporadic. Secondary, the other causes should be ruled out, like calcemia, hypoglycemia, hyperglycemia, or any CNS or central nervous system or peripheral nervous system trauma, multiple sclerosis, stroke, hyperthyroidism, and hypoparathyroidism. The most commonly, during the episodes, the child's consciousness will be intact. Limbs will be the most commonly involved. Also, face, neck, and trunk can also be involved. The frequency of episodes varies from 1 per month up to 100 per day, with the majority mostly having episodes during the daytime. Most episodes will be brief, which is lasting less than 1 minute. There should be any clinical criteria for paroxysmal kinase dyskinesia. It should be there should be a trigger for the attack, and it should be in shorter duration, and there should not be any loss of consciousness in during the attack. It should be excluding other organic diseases, and there should be a normal neurological examinations. Control of attacks with the anti-epileptic drugs like carbamazepine or phenytoin should be there. And the age of onset should be between 1 and the 20 years. There should not be any if there is no family history, age criteria may not be important in the familial cases. Such includes basal ganglia may play a role, hyperactive ganglia with spread to the cerebral cortex. A locus commonly will be PRRT gene on chromosome number 16. Other genes involved are SCN8A, CHRNA-A4, and SLC16A2. Diagnosis should be clean. More commonly, the diagnosis is clinically diagnosed of the movement. So, paroxysmal kinase has an excellent response to the anticonvulsant medications. The most commonly used drug will be the carbamazepine, which is the first line. Other medication. Carbamazepine is the first line drug used. Other medications described in case reports were lamotrigine, levetiracetam, oxcarbazepine, topiramate, valproate, and benzodiazepines. This case is presented to provide to bring the awareness among the primary healthcare workers about its benign course of the disease and tendency to have decreased attack frequency with the age, and its response well to the anticonvulsant medications.
Okay, stop sharing. Ma. Good presentation.
Thank you, sir.
Okay, but you need to present from a place where coverage is good. Okay, anyway, good. Stop sharing.
Okay, sir.
Stop sharing. Okay. So now the next case goes to Dr. Puvarigi Madam, Dr. Anuradha and team. Presenter Dr. Srinidhi from ICH. A case of hyponatremia with a hypertension, a diagnostic challenge. Others, please mute yourself. Srinidhi, over to you.
Yes, sir. My slide visible, sir?
Not yet, please. Okay, go for slideshow. Start with your presentation.
Good afternoon, one and all. My topic of presentation is the case of hyponatremia and hypertension using a diagnostic.
Srinidhi, slideshow, please. Go
So
for
we have
slideshow.
We had a 6-year-old male child with history of focal seizures involving the right upper limb and lower limb, with history of fever, abdominal pain, and lethargy for days, for which he was treated outside. On day 6 of illness, the child had recurrent seizures and was referred to ICH on day 7 as a case of acute CNS infection. His initial CBC done outside leukocytosis with negative CR. So when the child was his GCS was 15 with tonal posture was normal. On examining the child, he had no rashes nor skin infections. So he was not a known case of hypertension and he had no previous hospital admission. He was a second-born child to non-consanguineous marriage. He had no history of contact with TB or COVID cases. He was immunized up to age and was a developmentally normal child. On general examination, his GCS was 15. His BP in the upper limb was 130/90 and lower limb was 140/90. Cardiovascular, respiratory, and perabdominal examination were all normal, with CNS examination revealing brisk reflexes and bilateral extraplantar. So the CBC done at ICH revealed neutrophilic leukocytosis with the toxic granules. His renal function and liver function tests were normal. Sodium was 130. His case of examination revealed was normal with negative CBNAT and viral markers. The CT brain showed suspicious white matter hypodensity in bilateral frontal region. MRI was suggestive of bilateral frontoparietal occipital cortex hyperintensities with meningeal enhancement. So on day 2 of admission, we thought of press and Adam and
Srinidhi, you are not audible. Your screen we could not visualize, ma. Neither your slide nor your voice are heard. Please.
screen is visible now, sir.
Not yet. Initially, it was. You need to be in a place where coverage is good.
Is it visible now, sir?
No, ma. Yes, proceed, please. It is visible right now.
No.
Now it is visible. Proceed.
On day 2 mission, we
Sharath, again connectivity problem?
Yes, I think participants need to know that they need to be in a good coverage area, madam. Srinidhi, is it audible? Am I audible to you?
yes, sir. You're audible, sir.
Your screen is not visible. Is it possible to join later? Go to a place where coverage is good. John, are you there? John?
Yes, sir.
Yes, you can start sharing, ma. This is a case of secondary antiphospholipid. Again, Srinidhi started sharing.
Continue or shall I wait, sir?
If it is visible, you proceed. Otherwise, you stop sharing and you can join us at the end of the presentation. After the 7th case gets over. You please stop sharing, ma.
Stop now.
Okay.
You stop sharing, go to a place where coverage is good.
Okay, sir.
Okay, stop sharing. Okay, John, it's your time.
Yes,
It
sir.
is a case of secondary antiphospholipid syndrome in an adolescent girl with Sjogren syndrome. Presenter Dr. Arogya John, and from Dharani and Jayaraman and Mahesh Janardhanan, the team. Over to you, ma. The stage is yours.
Good afternoon to all. Good afternoon, sir. I'm talking about the secondary antiphospholipid syndrome in adolescent girl with a Sjogren syndrome. My guides, Dr. Mahesh Janardhanan, pediatric rheumatologist, Dr. Dharani Jairaman, pediatric hemato-oncologist from Srihar. This is 15-year girl child hailing from Nellore, informed mother by self, reliability was good. Brought with the complaints of bilateral lower limb pain, swelling, itching for 15 days, with history of discoloration over the fingers and toes for 10 days, and history of swelling over the fingers and toes for past 10 days. Past history, at 9 years of age, she presented with the low-grade fever and arthralgia with a history of recurrent parotitis for 6 months. Her investigation at that time revealed high ESR with the positive ANA and positive Rho and LA antibody with normal complements, and DCT was positive and normal urine examination. Salivary gland biopsy revealed features of Sjögren's syndrome. Hence, he was treated with short course oral steroid and HCQ. This is a histopathological slide showed salivary gland tissue massively infiltrated by the seeds of lymphoid cells with the prominent germinal center and enclosing salivary gland nests. This is a hyperplastic squamous epithelium with chronic inflammation in the subepithelial tissue. Other than nil significant history, menstrual history was irregular, not associated with any clots. General examinations, pallor was present, no interest, no cyanosis, clubbing, no lymphadenopathy, no thyromegaly, no signs of vitamin deficiency. Edema noted over the bilateral lower extremities. Puberty standard stage is 4. Vitals, afebrile, pulse rate was 90 per minute, respiratory rate 18 per minute. Blood pressure was 160 millimeter mercury. Saturation is 98% at room air. Head to examination. She was thin and emaciated. Gangrene of the second, third, fifth toe of the left leg and fingers, and discoloration of the first and fourth toe, and gangrene of the second and fifth toe of the right leg was noticed. Mild alopecia was present. There were no oral ulcer, arthritis, or rashes elsewhere. The clinical picture showed gangrene of the toes and discoloration. Her anthropometry revealed severe thinness. Systemic examination showed a CVS-RS per abdomen was normal, CNS is normal, musculoskeletal system, bilateral leg swelling was noticed, genitourinary system was normal. Her investigation showed anemia with lymphopenia. Other than the CBC was normal. Renal function, liver function, electrolytes was normal. Her viral markers was non-reactive and DCT was positive. Acute phase reactants were elevated with the CRP was 2.5, the ESR 100 mm at 1 hour with low complements. Her coagulation profile PT-INR was deranged. ANA was positive with 3+ fluorescence, and anticardiolipin, antiphospholipin, IgM antibody was elevated. Rheumatoid factor was positive with 1250. Beta-2 glycoprotein was elevated, and lupus anticoagulant was positive. Her extractable nuclear antigen showed strong positive of Sjögren's syndrome antibody A and B with Rho 52 and Smith antibodies. This is a ENA profile showed positive of SSA, SSP, and Rho and Smith A antibodies. Coming to the diagnosis, at 9 years of age, he had a recurrent parotitis with low-grade fever, arthralgia with a laboratory investigation suggestive of Sjögren's syndrome. With retrospective history, currently she presented with new onset gangrene with anticardiolipin, antiphospholipin, beta-2 glycoprotein was positive. Hence, we made a diagnosis of Sjögren's syndrome with a secondary antiphospholipid syndrome. Treatments, he was started with anticoagulation therapy with the subcutaneous low molecular weight heparin and IM methylprednisolone pulse therapy by 30 mg per kg for 3 days, followed by 2 mg per kg of oral prednisolone and cyclophosphamide infusion. Low molecular weight heparin was switched over to warfarin time of discharge, and INR ratio of 2 to 3 was targeted with a plan of anticoagulation at least 6 months, followed by a reassessment. Follow-up, at the time of discharge, the pain and swelling and gangrene was settled. After 3 months follow-up, the gangrene of the toe was well demarcated with no further spread of gangrene, and remaining anticardiolipin and lupus anticoagulant was remain positive. Coming to the discussion, Sjögren's syndrome is a systemic chronic inflammatory disorder characterized by a lymphocytic infiltrate in the exocrine glands like lacrimal and salivary glands. Adults are usually presented with the sicca symptoms like dry mouth, dry eyes, but children are presented with recurrent parotitis and systemic manifestations. The primary Sjögren's syndrome occurs without underlying rheumatological disease. Secondary Sjögren occurs with underlying rheumatological problems. Antiphospholipid syndrome, it's an acquired autoimmune disorder present with recurrent venous or arterial thromboembolism, recurrent fetal loss, and persistent elevated levels of antibodies act against membrane ionic phospholipids, example, anticardiolipin, antiphospholipids, and associated plasma protein like beta glycoproteins. Difference between primary and secondary aplas is a primary is usually younger age group and manifests as arterial thrombotic events like cerebrovascular attack. It occurs without underlying etiology. Secondary, it's occur in old age group, manifests as a venous thrombotic events like hematological and skin manifestations. It usually associated with underlying autoimmune disease. This is a case study stored clinical and immunological features of 121 patients of pediatric antiphospholipid syndrome. It's an international antiphospholipid registry of 121 pediatric children from 14 countries. Out of 121, 46 had lupus and 4 lupus-like illness. Others are autoimmune thyroiditis and other issues. The digital ischemia was the presenting manifestation of the 4 patients. Take-home message: children with a history of recurrent parotitis should undergo autoimmune workup, including extractable nuclear antigen profile like anti-Ro, antibodies, and salivary gland biopsy to rule out Sjögren's syndrome. Zika symptoms like may not be presenting features in children with Sjögren's syndrome. In children with existing rheumatological disease presenting with a new onset gangrene or stroke or DVT, secondary antiphospholipid should be considered. Promote anticoagulation and immune modulation therapy may be digital and life-saving method. This case report was accepted by the Indian Journal of Rheumatology. Thank you.
Thanks for being Chris. Okay, a very good
presentation.
Madam, shall we go for the next one? Am I Apurva? Can you stop sharing? Am I audible and visible? Okay, the next.
Yes, sure.
Okay, madam. I had a power failure at my home. Right, the next case from ICH, from M2 unit and Palmo by Dr. Fatima, a mystery of cystic swellings. Over to you, Fatima. Share your screen and proceed.
A very good afternoon to one and all. I'm Dr. Fatma, doing my final year MD Pediatrics at M2 unit at Institute of Child Health. I sincerely thank everyone for giving me the opportunity to speak here today. I request you all to join me as we unravel this cystic mystery. This case is that of a 7-month-old male child who was 5th born of 3rd-degree consanguineous marriage, who was brought by the mother with complaints of fever for 1 week, with bilateral cystic swellings on the forehead for 1 week. The presenting complaints were a high-grade fever with breathlessness for 2 days with bilateral soft swellings, no history of vomiting or loose stools, no history of air lossy or lethargy. There was a history of previous admission for 1 episode of unprovoked seizures where MRI showed bilateral frontotemporal atrophy. Child was started on AEDs and discharged. Birth history, the antenatal period was uneventful. There was a history of NICU admissions for 1 week in view of neonatal sepsis. There was no history of seizures during this period. The child was developmentally normal and had received immunizations as per UIP. It was a 3rd-degree consanguineous marriage. There were no significant family history in the previous 3 generations. The first child is an 11-year-old female child who is alive and healthy. The mother had history of 2 spontaneous abortions at 2nd and 3rd month of gestation. And this the 4th pregnancy was a stillborn male child at 8 months of gestation. This is the current child. On examination, the child was sick looking, tachypnic, there was pallor, there was an ulcer on the BCG side, bilateral cystic swelling were present on the forehead, multiple nodular lesions were palpable over the trunk and limbs. The child had hepatomegaly with a liver span of 7 centimeters. The spleen was palpable 2 centimeters along the axis below the left costal margin. This is an image showing cystic swelling. The complete blood count showed a leukocytosis with neutrophil predominance. The child had an anemia with hemoglobin of 6, platelets were normal, ESR was 57 millimeters per hour. Peripheral smear only showed an MCHC anemia. There were no specific findings on the smear. The X-ray, on the X-ray we can see that there are multiple lytic lesions in the humerus and also on the scapula, also on the calvarium. The long bones also show multiple lytic lesions. In addition, this bilateral posterobasal ground glass opacity. Excuse me, sir, just a second. The multiple hypodense. Multiple hypodense lesions are present in the liver as well as in the spleen. So at this juncture, to summarize, the child has fever, there are cystic swellings, skin lesions, and organomegaly. There are lytic lesions in the bone, both axial and appendicular bones on the X-ray. So at this juncture, what could it be? Our primary diagnosis was Langerhans cell histiocytosis. We did a bone marrow aspirate, but it was inconclusive. The skin biopsy showed there was histiocytosis. We did a CD68 stain, which was taken up, but when we did a CD1A staining, which is specific for LCH, the stain was not taken up. So what now? On re-examining, we saw that the BCG ulcer had deepened and the CBC showed a leukocytosis with neutrophil predominance. But on closer examination, the absolute lymphocyte count was below 2,500 on both occasions. So this prompted us to think of a primary immunodeficiency. We did an FNAC of the swelling on the in the frontal region, which showed gene expert for MTB was positive and it was sensitive to rifampicin. The immunoglobulin profile showed that the child had a hypogammaglobulinemia. Lymphocyte subset analysis showed that all the markers were deficient, and we diagnosed the child to have a T minus, B minus, NK minus variant of severe combined immunodeficiency. In view of this, we started the child on 800 milligrams per kg of IVIG. We started the child on ATT. Pyrazinamide was included initially because we could not rule out Mycobacterium tuberculosis. Child, in spite of all our supportive management, child went in for multi-organ dysfunction and succumbed to disseminated BCGiosis on the 13th day of hospital stay. BCGiosis is commonly seen in children with immunodeficiencies such as HIV, severe combined immunodeficiency, chronic granulomatous disease, Mendelian susceptibility to mycobacterial diseases. In this, if the child has interferon gamma receptor 1, then it is even more severe, and BCGiosis in this child could be fatal. The common symptoms present are fever, lymphadenopathy, hepatosplenomegaly, skin rash, hepatomegaly, skin rash, and osteomyelitis. In children with BCGiosis, we need to suspect the presence of primary immunodeficiency. In this case, initially we must look at the absolute lymphocyte count. If it is in a child who is less than 1 year of age, if the count is less than 3,000, then it is an indicator for immunodeficiency. From 1 to 2 years of age, if it is less than 2,000, and beyond that, if the count is less than 1,000, then we must be alert for immunodeficiency. The next step would be to do an immunoglobulin profile, a lymphocyte subset analysis, NBT and DHR. If we are still not able to diagnose an immunodeficiency, then we can proceed with interleukin 12 and interferon gamma defects. So BCG disease was classified by Talbot, which was modified for pediatric age group to local BCG disease and regional disease. Local disease is when it is confined to the site of vaccination. Regional disease is involvement of another lymph node on the ipsilateral side, which is usually the axillary node. In some instances, supraclavicular node can also be involved. Distant and disseminated disease is usually seen in immunodeficiency children. Distant disease refers to BCG confirmed from one site beyond the vaccinated site. In disseminated disease, it is more than one distant site with or without a bone marrow culture positivity. In case of local and regional disease, observation and EFI reporting is sufficient unless the ulcer or the abscess increases in size or there is a fistula formation, then we may proceed with an excision. In case of distant and disseminated disease, we start the child on ATT. The other manifestations of BCG include BCG iris in HIV-infected children who are on heart, in other BCG syndromes such as keloid formation with uveitis, or dual disease, which is local BCG disease along with pulmonary tuberculosis. The few instances of BCGosis age of have been reported. The age of presentation varies from 4 months to 72 months with a median of 24 months. Mode of presentation, as previously said, is most commonly fever with lymphadenopathy, hepatosplenomegaly, abscess, osteomyelitis, and lytic lesions in bones. The mortality rate for a child with PID and BCGosis is as high as 71.6%. The treatment is not just ATT, but also stem cell transplantation. So the take-home messages from this case is that in neonatal screening for primary immunodeficiency prior to vaccination can be considered. Mycobacterial infections are a close differential in an infant presenting with lytic lesions. Leukocytosis with neutrophilia does not rule out immunodeficiency. We must always look for absolute lymphocyte count. If it is less than 2000, thank you for your patient listening.
Okay, good, neat presentation, Fatima. Srinidhi, are you ready? Srinidhi?
Very nice presentation. Very nice presentation.
Thank you, ma'am.
Srinidhi, are you ready, ma?
Yes, sir.
Okay, da. You start present. Madam, shall we? Srinidhi, start your presentation, ma.
Yes, sir.
Okay.
Just a
Is this your presentation?
Is it visible?
No.
Is it visible, sir?
Yes, visible, proceed. And you are audible now.
Actually, Sharath, even your voice is lagging.
Oh.
Hypertensive rate, and we started the child on antihypertensives. Day 3 of illness, the child became irritable, had behavioral abnormalities in the form of anger outburst and using inappropriate words. His hyponatremia was persistent, and repeat CT brain showed hypertensive encephalopathy present. And his fundus was normal, and ECG echo also showed a normal study. On day 4, the child was intubated in view of poor GCS and persistent seizures. He had metabolic alkalosis, persistent hyponatremia, and hypokalemia, and the child was received in PICU. Initially, diagnosis of acute CNS infection. Raised ICP and SAADH was made in view of hyponatremia, raised urine osmolarity, decreased serum osmolarity with normal glycemic status, no diuretic usage, and normal thyroid function test. Since the child was to infection scrub and Whitehall were negative, the CRP was positive, CBNAT and MAN2 were negative. These inflammatory markers were elevated with raised triglycerides, ferritin, procalcitonin, and interleukin 6. His urine examination was normal with no RBCs, and spot PCR was 0.3. Imaging revealed a normal chest X-ray. USG abdomen was normal with normal kidney sizes, and renal artery Doppler was also normal. So this is the trend of hyponatremia during his course of admission in ICH. On day 5, since the child was persistently hypertensive, we shifted to labetalol infusion. His LFT also started deranging, and his CT brain was evident of rest. His RT-PCR and antibody were negative. On day 6, the child developed high-colored urine, and autoimmune acute intermittent porphyria was thought of in view of neuropsychiatric manifestations, abdominal pain, and multi-system etiology. So ALA, serum phosphorbilinogen were all sent. This urine urine analysis showed plenty of RBCs with spot PCR of 2.4. Nephro opinion was obtained and was advised to rule out rhabdomyolysis. Hemoglobin, platelet, and total count started declining on day 7 with persistent hyponatremia, seizures, orofacial dyskinesia, and CPK was more than 50,000. On day 8, the DDs we thought of were autoimmune encephalitis, pan-SLE, in view of persistent seizures, fever, orofacial dyskinesia, and behavior abnormalities, and started the child on methylprednisolone. So this is a child with high-colored urine. On day when field echo showed a mild LV dysfunction with EF of 44%. Labetalol was stopped and was shifted to alpha-methyl-dopa and nifedipine. The child was extubated on day 12. His fundus examination revealed attenuation with disc failure. His VMA reports are as negative. Serum ALA, porphyrin, and phosphorbilinogen are all normal. So rheumatologist opinion was obtained to rule out any vasculitis causes, and CT abdomen angio was suggested by them, which also turned out to be normal. Meanwhile, his ANA, anti-DS, DNA, C, ANCA, P, ANCA were all negative. The C3, C4 were normal. On day 17, the child was discharged with AEDs and antihypertensives. So at the time of discharge, the sensorium had not regained to the basal level. He had hypertonia and contractions. MRI was suggestive of stress, and he had loss of vision. His echo revealed a mild LV dysfunction with EF of 44%. His LFT initially deranged, but at the time of discharge, it became normal. So at the time of discharge, he had persistent hyponatremia. Renal Doppler was normal. So on further follow-up, we thought of doing renin and aldosterone levels and also digital subtraction angiography. Initially, we thought of ruling out the causes of hyponatremia. Since the child had hyponatremia with low serum osmolarity and with elevated urine sodium with eulemic status, SAADH was only in our mind. Evaluating various literatures, we came up with a syndrome entity called hyponatremia hypertensive syndrome, for which the following are the etiologies from various literatures. Ruling out each etiology, we were left out with renal artery stenosis. But since CT abdomen angio and USG Doppler were normal, we cannot entirely rule out the possibility of renal artery stenosis. Because both the CT abdomen angio and Doppler are only 88% and 80% sensitive in detecting intrarenal renal artery stenosis. So if you strongly suspect a case of renovascular hypertension, it is traceable to digital subtraction angiography and serum renal renin sampling. So this hyponatremia hypertensive syndrome is an entity comprising of hyponatremia, hypertension with proteinuria, hypokalemia, polyuria, hyperinsulinemia, and hyperaldosteronism. So the pathophysiology behind this is unilateral renal ischemia, which stimulates the adrenal gland to secrete increased aldosterone, which causes sodium chloride reabsorption, water retention, which in turn causes hypertension and diuresis and natriuresis of the opposite kidney, thereby causing hyponatremia. So as I said, both Doppler and CT angio are not sensitive enough in identifying intrarenal renal artery stenosis. However, the gold standard is renal arteriography. The drugs are used as AC inhibitors in unilateral renal artery stenosis, and the surgery mode of choice is percutaneous luminal angioplasty. So these are my review literature. I'd like to thank Professor Dr. Puvalagi ma'am and Dr. Anuradha ma'am, medical unit, and the entire nephrology, neurology, and hematology team for providing me with this opportunity. Thank you.
Okay, thank you. Nice finish after an initial hiccup. Thank you. Stop sharing. Now let us, okay, ma. Now let us go to the chat box regarding the questions. Okay, gangrene. The first question goes to, 1 second. With respect to our case, is there any dysmorphology? We don't think so. And with respect to bird-like feature, we don't think so. Nedu sir has asked, have you ruled out histiocytosis beyond doubt? Neither histopathology nor immunochemistry is suggestive of histiocytosis, sir. As well as CB0 is turned out to be positive, along with all other investigations with respect to immunoglobulin profile and lymphocyte subset analysis are turned out to be in favor of a T minus, B minus, and NK minus SCID. And with respect to previous fetal loss, stillbirth explained by PID, no, we don't know. We really wanted to search for the diagnosis behind this stillbirth and fetal loss. We don't think any PID will lead to fetal loss and stillbirth because the majority of them will die of infection. In vitro, it is not possible to our knowledge right now. Karamat, you want to add something here?
No, that's fine, sir.
Okay, then. Right. And as far as BCG is concerned, better to see absolute lymphocyte count. It is not practiced anywhere else. But since BCG is a live attenuated vaccine and we have been seeing many more cases of severe combined immunodeficiency, better to see an absolute lymphocyte count before giving a BCG vaccine. And with respect to other cases, regarding from John, gangrene only anticoagulation. Since I had lost my connection, only some questions are visible to me. Okay, is it possible if you have some questions, anyone can proceed with? Since I lost connection, I don't have any previous messages from my chat in my chat box. Kara, is it possible for you to proceed? Karamat?
Hello.
Karamat.
I think all of them can see the question. The first question was, is PET routinely indicated in all kids with that was asked. I think Venkateshwari has answered. And Venkateshwari asked that question.
Sir, I am Dr. Ranjit. Can I answer the question? Hello?
Yes, boss.
Yeah. Even Vasant has asked, why was the PET CT done earlier? So both questions are looking same only. So after ruling out the initial 4 differential diagnoses, we had only Rasmussen encephalitis versus autoimmune encephalitis as 2 differential diagnoses. We kept Rasmussen's also in the loop because all the seizures which were occurring for this child were typical unifocal origin arising from the right angle of mouth, all the seizures. So new onset focal refractory seizure in otherwise premorbidly developmentally normal child could also be a Rasmussen at its initial stage. In the initial stage of presentation of Rasmussen, MRI may not show hemispheric atrophy. Initially, MRI may be normal. Later, it turns out to be hemispheric atrophy. So it will be difficult. So we did a PET CT to differentiate between these two. Rasmussen encephalitis shows unilateral hypometabolism in the PET CT, whereas autoimmune may show non-specific changes which may be diffuse. Another differential diagnosis is also structural. Like although MRI may be negative, we may have focal cortical dysplasias which are very occult, which may not be picked up in the very advanced MRIs also. So which can also be picked up in PET scan. So whenever required, we do. And he was asking why was it done when we got anti-GAD is positive. Anti-GAD took 2 weeks for us to get the reports and for us to find out. So we need to have a diagnosis before that. That is the reason we went ahead with the PET CT brain. And another reason is it is available easily in house, so there was no difficulty in getting it done also.
Thank you, sir. I think there was the next question was regarding correction of hypophosphatemia. Again, answered in the chat box. Probably he can explain it here.
I'm Dr. Vasant here. Basically, this child has severe hypophosphatemia. Am I audible?
Yes, sir. Go ahead.
So severe hypophosphatemia is only 0.8. So in such situations, we give IV phosphorus corrections. Because in DKA, because of insulin, there will be hypophosphatemia and there will be hypokalemia also. So we usually give it in the form of K-phosphate, which is like you dilute it in around 10 ml of saline and give it over 24 hours. So usually one dose of IV correction is sufficient most of the times. Because severe hypophosphatemia itself can cause some amount of cardiac dysfunction too. So that is the reason why IV correction was given. The point to be noted is that it has to be given as a continuous infusion over a 24-hour period, at least over 12 hours. Slow infusion is required.
Subsequently, Sarath had asked regarding acidosis causing cardiac dysfunction.
Yeah, I think with respect to usually, as we all know, DKA can cause acidosis. The concern is when there is persistent acidosis. So any acidosis, as Dr. Sharath had rightly said, can cause cardiac dysfunction. But we always need to know why it has happened. So in this case, the usual reasons are in DKA is like hyperchloremia, inadequate insulin, dehydration. But in this situation, all of those were already corrected. So all of those were already corrected, and this child landed up in persistent acidosis and AKI. So what we are trying to say is, the acidosis has not caused the cardiac dysfunction. The cardiac dysfunction has as such caused the acidosis, persistent acidosis, and for shock. So any child basically who has persistent acidosis, in addition to the usual causes of inadequate dehydration, inadequate insulin dose, hyperchloremia, and AKI, and sepsis, we'll have to think of cardiac dysfunction also. Or any child with recurrence of acidosis, or any child with persistent shock or new onset shock. So in such situations, it is better to think of cardiac dysfunction also in addition to the usual causes. Because this child was referred to us for RRT. There is no urine output at all, like less urine output for the last 5 to 6 hours. And there was acidosis, new onset acidosis. So in case if you had not done an echo or something, you would have landed up in RRT. So a simple investigation like a bedside echo, like even just by eyeballing, can help in preventing that unnecessary treatment. That is the basic point.
Thank you. I think this is for Janani ma'am's case. Cataract in the case of recurrent hypoglycemia, asked by Nedijarian sir.
In our child, actually, we didn't suspect galactosemia in the first place, but as sir said, we need to look for cataract in any child with present with recurrent hypoglycemia. This child did not have cataract.
Again, next is probably for Stanley. Differential diagnosis for paroxysmal dyskinesia and how to differentiate it from petit mal seizures. Again from Nedijarian sir. Where is Sami sir?
Hello. Hello.
Yes, sir.
Am I audible?
Yes, sir.
Petit mal seizure, usually there will be loss of consciousness, loss of awareness will be there, and there will not be any posturing. In this case, the child had dystonic posturing in both upper limbs and lower limbs. So there is no impaired awareness, and there is a dystonic posturing which is against petit mal epilepsy.
Differential diagnosis for this dyskinesia, sir?
That already she has mentioned, paroxysmal other secondary causes, hypoparathyroidism, hyperthyroidism, and structural brain lesions can cause paroxysmal dyskinesias. And paroxysmal exercise-induced dyskinesias and paroxysmal non-kinesogenic dyskinesias. These are all the differential diagnoses. Non-kinesogenic dyskinesias usually will be precipitated by excitement, stress, and caffeine ingestion. Paroxysmal exercise-induced dyskinesia will be occurring after prolonged exercise. Here it is precipitated, triggered by sudden movement. There is kinesogenic dyskinesias.
Thank you, sir.
And so usually exercise, yeah.
There is one more question regarding carbamazepine and phenytoin. Okay.
Yeah, there is a cross reaction. Yes, it's well known. Patients allergic to carbamazepine will be allergic to, maybe allergic to phenytoin, maybe allergic to phenobarbital also. But in this case, we have no option, so we have tried phenytoin because these are the two drugs that are effective in this case, either carbamazepine or phenytoin. So the drug of choice is carbamazepine or oxcarbazepine. So luckily, this patient didn't have any cross reaction. Ideally, we have to do HLA typing before starting carbamazepine. HLA B1502 has to be done before starting carbamazepine. But because of financial constraint, we have not done HLA typing. But luckily, child had no cross reaction to phenytoin.
Thank you, sir.
And genetic study we have not done again for financial constraints. And this case is presented for its one for its rarity, and second, it is a treatable disorder. Though it is rare, it is a treatable disorder. One should be aware of about this condition. Most commonly, this is sometimes it's diagnosed as a psychogenic movement disorders. That is a common misdiagnosis. So that's just to bring out some awareness amongst pediatricians. This case is presented.
Thank you, sir. I think, Sarath, we have all answered all the questions.
Okay, thank you. Thank you, Karamat. I think we have done with this. And already 2 slots were booked by KKCTH and Rainbow for the January meet. With this, we are finishing right now. Okay, thank you. Thanks for your patient listening. Thank you, faculties. Thank you, presenters. So we can log out now. Thank you all.
Wish you all a very happy new year.
Thank you, madam. Thank you, madam. And the YouTube link will be provided tonight. Thank you. We'll end the session.